Welcome to Psyched for Psychology, a Nystrom & Associates podcast. Our hosts, Michelle Iverson and Brett Cushing, are both licensed marriage and family therapists at Nystrom & Associates. Each week, they talk about all things mental health and therapy, and you get a chance to dive into specific psychology topics that help promote personal development and wellness. And now, here are your hosts, Michelle and Brett.
Welcome to another edition of Psych for Psychology. My name is Brett Cushing, and I'm with
Michelle Iverson, and we are talking today about the most, or some of the most, misunderstood diagnoses when it comes to mental health.
So why would we want to talk about this? Why is this relevant for people that are listening today?
Well, I think because a lot of people have a certain a basic misunderstanding of how a lot of certain types of mental health diagnoses work. And when we don't understand how a mental health diagnosis works for people, what they experience, what it's like to live with it, that increases risk of stigma. It also increases risk of even things that might seem harmless, like a joke, right? I'm going to make a joke about how I might have XYZ diagnosis. Mm-hmm. And then that minimizes, that trivializes what it's like for that person to actually live through it. Even more so when what they experience is very debilitating and scary.
Yeah. So we want to create more understanding because of what you're saying. When we don't, there's harmful consequences. And I also find that when we don't understand things, the more we don't understand, the less tolerant we are. We become very intolerant of things we don't understand. Simply, an illustration would be when I'm driving and someone's super slow in front of me and they're kind of all over the road and I am incredibly intolerant of that because I don't understand. Then I pull up next to them and I realize, oh, it's two older ladies. They're from Utah, and they don't really know.
Suddenly I get all this context.
Right. All the context, like, oh, okay, now I understand. I'm so much more understanding and tolerant and compassionate. So these are all things that we are hoping people will come away with this understanding and a greater sense of tolerance, but beyond tolerance, compassion and a willingness to come alongside and help people.
And we've actually done this 2 times before in our podcast in prior episodes. We did a podcast episode on psychosis and a lot of the myths and the stigma around psychosis. We also did one on borderline personality disorder, which again, another diagnosis that a lot of people are like, maybe I've heard of it, but I don't quite understand it. Or what I do understand of it is very different from what it's like to live and experience having that issue.
Right. And we'd like to tackle this because we really hope that as we talk about these topics, we're moving from a standpoint in terms of mental health, people with mental health disorders, from a standpoint of what is wrong with her to, I wonder what happened to her, moving from criticism and contempt to a position of real, genuine, and deep compassion towards other people. So today, I know we're going to be talking about 4 common ones, dissociative identity disorder, narcissistic personality disorder, pyromania, and OCD. And I know exactly what you talked about just a moment ago, that we use these very flippantly, like, ooh, we build a bonfire, I'm a pyromaniac, or just because I like my house especially clean.
Kind of neat and clean.
Yeah, you must have OCD.
Let me make jokes about how OCD I am.
Right. Yeah.
Right.
And it's understandable.
Yeah.
But
at the same time, there are people who you could be making that joke to someone who actually lives and deals with a very debilitating form of OCD every single day. And that's going to completely minimize, trivialize what they go through. And so we're going to talk a little bit about what kind of makes these some of the, from our perspective, some of the most misunderstood diagnoses. What is it really like, not only for us as clinicians to help and treat that diagnosis, but also for those people who are living with it. So we can learn how to be able to really understand what this is like and have that compassion and understanding.
So let's jump in with the first one. Dissociative identity disorder used to be called multiple personality disorder. This one, I find a lot of people, they not only misunderstand it, they're kind of scared by it too, because it's there's so much misunderstanding, and it seems kind of freaky, to people.
Yeah.
So tell us a little bit about dissociative identity disorder.
Well, what's really interesting about this one is I think a lot of people only get introduced to it through media, through movies, books, TV. Did you ever read or watch Sybil?
Yes.
Yeah.
I remember, I think I was in high school, right?
Yeah.
Tell us about, what was Sybil?
Well, I actually never had the chance to watch the movie or read the book, but from what I do know about it is, it was supposed to be this, true accounting of this woman's experience with, at the time, called multiple personality disorder, how her treatment with her psychiatrist. I do think it was a pretty big motivating factor for what eventually got dissociative identity disorder added to the DSM. Our book, our guide for understanding and diagnosing mental health concerns. There was a lot of controversy around it as well, too. A lot of, which, unfortunately has kind of caused some even controversy around this diagnosis in the community. A lot of people thinking, well, could this be kind of implanted into people's minds? The real woman behind Sybil was experienced hypnosis with her physician, and could that have, there's a lot of, it brings up all this idea of controversy, but from there, and for a lot of people, for that to be their first exposure to what this is, then you start to see more representations of this in the media that are really unhelpful. So when I think about our movie podcast that we did, that we'll do a link to too, because it was a really great one. I didn't get a chance to talk about this on there, but this is another good example of how a movie really misrepresents a real illness for people. And so this movie, the movie Split, it was James McAvoy. It's related to some of the other kind of movies with, what was it with Bruce Willis? The other one that's related to, that was the big twist at the end, was you find out it's related to a movie with Bruce Willis, and I'm completely blanking on the name of it. But anyways, the movie Split, you've got James McAvoy's character. He's the antagonist. You're told in the movie he has 23 different personalities and dissociative identity disorder. One of these personalities is dangerous. It's the main villain of the story. Essentially, this movie becomes a horror film where he kidnaps 3 girls. That, again, really twists and turns this into, rather than an illness of somebody experiencing, into a horror film. And it was really interesting that after that movie came out, there is a psychiatrist. She's a dissociative identity disorder specialist at Mount Sinai School of Medicine, Dr. Garrett Marie Deckel. She got an email from one of her own clients who has DID as a diagnosis. And the client said this: there's a new movie out about a person with DID. It's a thriller horror movie, she wrote, referring to that movie Split. And she said, "Do I ever scare you?" That's the type of impact that this has on clients who are dealing with this very real disorder. So what is this really? It's not the movie Split, right? It's not any depictions like that in the media. What we're really looking at is somebody who's just trying to escape reality, often because they've experienced trauma like abuse. The key characteristics of DID is this person shifting between these separate identities that they have formed inside of themselves because they are trying to escape trauma. So yes, we might see in the media that these personalities might have different names, traits, mannerisms, even distinctive voices. And when that person switches between these personas, they might experience gaps in their memory. They might get out-of-body-like experiences. They might even feel these voices trying to control or possess them. But that's scary. And
yeah,
that
the
person,
irony. They're the ones that are scared. We talk about
ones.
this being a horror movie, and we talked about this in the media podcast that we did. And tragically, the real horror and the real scary aspect of this is for the person who has it. And think of what you alluded to, so many people who have this have already experienced some horrific trauma in their lives. And that is pain enough. We don't need to add insult to injury here by all these connotations and cultural representations of this disorder.
Somebody with DID would be more likely to experience anxiety and depression, far more likely to hurt themselves than anybody else. And in fact, out of this population, more than 70% has attempted suicide. And that is really significant.
Yeah, that in and of itself ought to move the needle much more towards the compassion side rather than the criticism side. And, you know, it's funny in a way to oversimplify this to make a point. We do this. We put on different personalities ourselves to deal with things, don't we? You know, I remember, you know, my mom would be upset with me when I was a kid and, you know, now you sit there and you think about what you did. And then suddenly the phone rings. Hello, Cushing residence, you know, and I'm like, whoa, what? Yeah, it just gave me whiplash watching that. But, you know, we put on these different personalities to cope. And that's a very simplistic, overly simplistic way to think about it. But I think it does create a sense of understanding that, oh yeah, we do this to cope. I used to watch MASH growing up, the TV show MASH. Love MASH. I alluded to that in another podcast on the media. And Alan Alda, like, played Hawkeye, who dealt with trauma through a lot of laughter and humor. And many comedians do that too. They've had trauma backgrounds and this is the way they deal with it. So in a way, this is the brain's way of dealing with really horrific trauma.
So we want to kind of get away from these media depictions of DID that are really just sensationalized. There's a psychologist in Cleveland that is also a specialist in this area, Dr. Peter Barak, and he says, really, we want people to know that people with DID, they suffer greatly. They do everything they can to try to hide and try and cover their symptoms because they're finding it to be embarrassing and often debilitating. And so with treatment, a lot of what we're doing is trying to help clients with ultimately their trauma. CBT, cognitive behavioral therapy, DBT, dialectical behavioral therapy, and EMDR are all focuses that we're going to be doing with treatment for clients who are experiencing this. Especially with a focus on how do we take care of the trauma that tends to be behind use of this particular kind of coping mechanism in a way.
So hopefully we will understand is we want people to understand our own coping mechanisms that may not be the most helpful. I've got really unhealthy coping mechanisms of my own in everyday life, and we all have them. And just realizing that people have dissociative identity disorder, it's a coping mechanism. And maybe understanding that can help us come alongside of them. Now, another one that might even be more difficult is the narcissistic personality disorder. I hear this a lot. You know, and we live in such a hyper-individualized culture that it does get thrown around a lot. That person is such a narcissist. And it's just this armchair quarterbacking on what people see and what they experience. And yet we're not informed. So inform us, Michelle.
Well, we've also, as therapists, I was thinking about how many times do we get people coming into our office and asking, is so-and-so family member, friends, let me tell you what they're doing to me this week. And are they a narcissist because of it? We get that a lot. But we're not talking about, when we're talking about true narcissistic personality disorder, we're not talking about somebody being self-absorbed, vain, or full of themselves at times. Some people might have mildly narcissistic traits but to have this full diagnosis, we are talking about something debilitating, something that is very much affecting their life and their relationships. And so if you have this diagnosis, this is somebody having a significant pattern of being very grandiose. I need to feel superior and get recognition of that. I need to have constant admiration of myself. They might experience very significant fantasies of success, power, beauty, and become very preoccupied with that. Very unreasonably entitled, exploiting others. But really importantly too, they lack empathy. I can't identify with the feelings, the needs of other people. which then is going to come off as some pretty extreme arrogance and maybe envy, both envy of other people or thinking, Brett, you obviously are envious of me.
Right. And I think what you hit on there is what is so extremely difficult for those of us that are living with somebody who is a narcissist, because successful relationships do require some level of empathy and understanding and being able to sort of get into another person's world. And the narcissist just doesn't have that ability. And so we misunderstand that as they're choosing this as opposed, and we're assuming actually they have a capability to do it, and they don't. And so that just doesn't compute in our mind. And like we've said all along, what we don't understand, we become very intolerant of.
Well, a lot of people have a hard time empathizing with it, especially if that person's not empathizing with me, cares about my feelings. It's going to make it that much harder for me to empathize with them. But here's the irony that comes with this diagnosis that maybe can help with understanding and empathizing with it. The irony is that somebody with this disorder, narcissistic personality disorder, even with all those traits that I just described, they have some of the lowest self-esteem. So you're essentially looking at and seeing a very hard exterior. And underneath, we find that there's a very fragile person underneath who essentially is, acting in this way, showing this to others because they constantly need to know how they're being perceived because of that fragile, low self-esteem. If they get criticized, that person underneath is actually feeling humiliated, degraded, empty. And what they're doing is actually attacking then with either rage or with disdain.
And yeah, we don't deal well with anger in our culture. That'd be an interesting and I think relevant topic for us about anger, because anger it's funny because people don't like to ever admit that they're angry. I find, I respond to clients like, wow, you sound kind of angry. Oh, no, I'm not angry. I'm just frustrated. And so we have this weird relationship with anger. And so we see these people that we're really frustrated with because they have no empathy. And then they react in anger. And it's sort of like you throw your hands up and like, I'm so done with this person. And ironically, now we don't have any empathy for them either. And it's tragic.
We can start to see how it becomes debilitating. How many friendships, family member relationships, even like a job that you could lose, and many clients do lose because of this very extreme but negative reaction to not wanting to be hurt.
Right. And so I think this highlights why we keep trying to pivot away from the question of, I wonder what's wrong with him, to, I wonder what happened to him, because you had said that this results from low self-esteem. Well, what happens, do you think, to people where they have this lower self-esteem? Where does that come from?
And the hard part, too, is that not only where does this come from, well, how are we going to find out? We're going to probably need to do some long-term counseling. But these are going to be the clients that are going to be less likely to want to come in. They're going to be less likely to recognize that there's a problem or an issue. Many, in fact, don't come in until a loved one, somebody says, hey, like you need to go, or something very significant has happened. Like they've lost their job because of this. Sometimes that is maybe the only thing that could prompt that person to go in to seek help to figure out why this is happening.
Which is a tricky thing, because you want to appeal to reason, and that appealing to reason with this person is going to elicit an intense emotional reaction. And so then if you don't have reason, what else can you do to try to connect with this person? Which ironically will be in a future podcast. We'll be talking about why you won't listen to me. So it is exasperating for those who are living with somebody who has narcissism.
So for these people, this isn't going to go away without long-term counseling. And they focus the counseling on how do we help you to relate to other people in a positive, rewarding way? How do we help you develop healthy self-esteem? And then to have more realistic expectations of other people. Medication might be recommended too, but most importantly, it's going to be a willingness to change and accept help, which ironically is probably going to be one of the hardest things for them. But that is going to be the most important aspect of treatment for that person for recovery.
Yeah, it's exhausting. It's exhausting for the person. It's exhausting for their loved ones. And all the more need to really emphasize the need for compassion and trying to understand it, at least, especially because it's so hard. Well, the next one we're going to look at is pyromania. I don't know if I've ever been at a bonfire where someone lighting the fire hasn't said, I'm such a pyromaniac. So is that true? Are they all pyromaniacs, or is there something else going on with pyromania?
So here's the thing about pyromania. This is not just about liking fires.
What? I mean, that's what I've always seen and always heard.
Right?
It's all about the fires.
Yeah, that's the joke. Whether it's not necessarily like we might be kind of making fun of ourselves, but at the same time, that's again minimizing what we actually will see when somebody has true pyromania. This is not just about liking fires. This is you intentionally setting them. So really, in order to get diagnosed with this condition, we need to see somebody's deliberately setting fires more than once, but they're just displaying other things too, like excessive fascination with fires, gratification or relief after it happens, and really that person is truly getting psychological benefit from it. So you're not setting fires because of monetary reasons, right? Like I'm going to burn my house down for insurance money. That wouldn't be the case. You're not doing it for vengeance or even because of another mental health condition. It has to be very, very specific to this build up of, it's almost like tension, a build up of tension, thoughts and feelings, sometimes obsessions over, I need to set this fire, and then getting a psychological relief.
Obsession is a good word. I also think of, to help me understand this too, is like addiction. You know, somebody just, I need that release. So I need that drink. I need that drug. I need that behavioral addiction. And then I get this whoosh, you know, this rush of emotion that is satiating now for me and satisfying.
Yeah. And none of this that I'm going to say next is criteria. Like this isn't what we would use to just diagnose somebody on its own. But what's really interesting is that research has found that people with pyromania tended to display certain behaviors, certain traits. They tended to be regular finders and watchers of fires in the area, right? If there was a fire down the street, they would be down there going to watch it, going to these scenes frequently. They might frequently set off false fire alarms, might spend lots of time at local fire departments, and sometimes even become a firefighter themselves. Which is really interesting.
But that totally makes sense.
Yeah.
Yeah. Absolutely. I mean, that seems like the ideal job. And I remember there was a movie, Backdraft, with Kurt Russell. Love Kurt Russell. And there was a guy who kept setting, he was a fireman and kept setting fires all the time. He wasn't, I don't think, technically diagnosed with pyromania, but there was this fascination in the movie about fire and its power. And there's this allure to fires that you're just drawn to, almost like a mosquito to the light, you know, like I can't help myself.
And I think here's part of where the misunderstanding around pyromania really comes from too. We don't really have enough research and information to know here's what age it starts. And the thing with fire setting, it actually is a big problem with a lot of kids and adolescents. In fact, over 40% of arson offenses are actually kids under 18. But true pyromania in kids is very rare. Kids setting fires is actually more due to different things like a conduct disorder, maybe ADHD, or other types of adjustment disorders. And even the idea of kids just playing around with like lighters, matches. Some psychologists actually see that as more of developmental experimentation. So, and maybe a little more of like normal childhood development, rather than pyromania.
Right. So parents, don't worry. You know, if your kids are doing this, doesn't mean they have pyromania. We're not saying, just go give them a bunch of matches and let them, you know, work out their developmental, you know, advancement. But it's not something to just automatically think my kid has pyromania. I do remember kids, you know, I remember myself, like, you know, doing this. And I remember there was a kid down the block he set his parents' garage on fire. It doesn't mean the kid was a pyromaniac.
Right.
He was just things getting out of control there with the matches.
Right. Absolutely. Complete accidents, or even if it was another mental health condition, even still, we don't have to feel, because we have no research that says that there's a direct correlation between things that happen pretty frequently in childhood to pyromania, as it is here.
Yeah, and I think with pyromania, it is a difficult one for people to understand. We like to throw it around very casually. And I think what we can do with all of these disorders, even as we head into this last one, is to be able to say it very intentionally, even if it doesn't come naturally, but to very intentionally still say, it makes sense. Because that's so validating to the person and their struggles, is to be able to say, it makes sense that they're drawn to this. I don't get it, but it makes sense to them. Whether somebody has dissociative identity disorder, somebody is dealing with pyromania, or they're narcissistic, for us to be able to say, it makes sense that this is a struggle for them. And especially for this last one that can drive us a little bit nuts too. OCD, or obsessive compulsive disorder, it makes sense.
What do you commonly tend to hear from people who think that they have OCD or think they know someone with OCD? And what kind of examples do they tend to give?
I think of cleaning. I think of...
Like, I'm a neat freak. I like to clean a lot.
Right. And I have these obsessive compulsive deals with thoughts and then behaviors. So I have these obsessive thoughts that result in compulsive behaviors. So, I obsess so much about, all right, I'll self-disclosure. Okay. If my wife is listening, she'll be like, oh, totally. He does this. Vacuum lines. I like to vacuum, and I love having the vacuum lines in the, carpet in the front room, and even in my couch in my office. I love my vacuum lines, and it's obsessive for me, and it results in compulsive behavior. Does that mean I have obsessive compulsive disorder, Michelle?
I don't think so, because what we're really looking at is that we've got lots of people, there's lots of personality traits. I mean, I totally get what you mean with the lines and seeing the nice lines. And do you ever see those? Sometimes they're like videos or memes online, and you're watching something just going in like a very perfect circle or some other pattern that's just really nice, and then they mess it up purposely at the end and it just drives you crazy. I love but hate those videos for that exact reason. A lot of people might jump to, well, then I must be OCD, because that really bothered me. Or if I'm very particular about the vacuum lines or where things should go in my house, or if otherwise, like, people think of me as like this quirky perfectionist and neat freak, a bit of a germaphobe.
Yes, the germaphobes. Right. They're all OCD, people think. Right.
But true OCD, we are talking about something so much more, and especially debilitating. But that's the issue. So many people, there are so many jokes, memes in particular about OCD, that again, it's perpetuating stigma, this misunderstanding, and minimizing what it's like to suffer with this. When you're suffering with this, you are having a lot of distress. So obsessive compulsive, that describes two core aspects of this illness. You don't need to have both. You could have one or the other, but you could have both too. So you could be having obsessions. We are talking about intrusive thoughts.
What's an intrusive thought?
A thought that feels uncontrolled and often distressing, is going to cause you anxiety, extreme distress. And you can't very easily say, well, I'll just go distract myself and think about something else.
And you can't control when it happens.
And when it happens, or how long it goes for, right? And that's going to be a really key part of this illness. And the other part, compulsions, we're talking about repetitive behaviors or mental actions. When I say mental actions, I mean things like counting over and over again, and maybe in certain patterns or certain ways. Those compulsions happen because they're trying to help with the obsession. So obsession occurs for some people, maybe not all, but for many, then I'm going to do a compulsion to try to get relief. So let me give an example of all that. Excessive hand washing. So again, a lot of people might think they might be OCD because I kind of wash my hands maybe a little more than usual, than other people even. But even then, when we're talking about OCD, we'd be seeing somebody doing that at least an hour every day.
An hour. That's
a
sobering to
lot.
think about that. How
Yes.
we think about things that are intrusive thoughts. That's intrusive into one's life and quality of life.
And even then, it's not even just that how much and how often you're doing it, but they're doing it because they are having distressing, intrusive thoughts about scary things that will happen to me if I do not do this, right? And often the scary things are very outsized, right? Like this very, like, I will die if I do not engage in this for an hour every single day. That would not be the same as somebody just being like, oh, I wash my hands a little more than usual.
Right.
Often people will experience contamination fears, maybe even intrusive thoughts of like scary or violent scenes in their head. And then other thoughts that if they don't engage in that, again, something bad is going to happen to them or to people that they care about. They might get relief when they do things like excessively checking all of the locks in my house over and over and over and over again. They might get relief, but they're not getting any real pleasure from it, right? If you're getting pleasure from seeing like the nice vacuum lines in the carpet, that's wonderful. But that's not what's happening for somebody with OCD. As many as half of people with OCD also end up having suicidal thoughts as well because of the intensity of these symptoms.
So these people are really suffering.
Yes.
They're suffering. How often? Like once a month is this happening, do you think? Or it's just seasonal? How often are these people struggling?
We're talking about every single day.
Yeah.
Every single day, without fail. And again, that's part of the illness. It's without you really wanting this to be happening. You're doing it anyway.
The analogy I think of is I was at my brother's in Red Wing, and they had all these flies. For some reason there was all these flies. And man, they were just chewing up my legs, and I was itching like crazy.
Yeah.
And you're not supposed to itch, right? But I was ready to itch my skin off. I mean, I couldn't stop.
Yeah.
Right. So my mind is telling me, man, this is really itchy. And so I'm scratching. And like, oh, it feels so good. But yet it didn't at the same time. And it was the more I scratched, the more it seemed to itch. And I had no sense of relief from this. And this went on for like a week. I kept putting stuff on, my sheets would like touch my leg at night. I'm like, oh, I still want to, And so I think people can relate to that a little bit and might give us a little bit of insight and inside track of this is what people with OCD are dealing with. As you said, it doesn't go away in a week. It's every day.
Yeah. And there's no bug bite, but it's happening anyway. And it's often happening because you have this very scary, intrusive thought about what's going to be the bad thing that's going to happen if I don't do this. So it comes down to how much of an impact is this having on that person's life, which is true for so many of the mental health disorders that we, work with and we help people with. How much of an impact is this having on you? If somebody's avoiding friends and family because of fears of contamination, or they're risking losing their job because they're engaging in these like counting or arranging rituals, things that cause them to never be able to leave their house on time. That's very different from that being a bit of a germaphobe or a neat freak. But lots of people recover from OCD. It's a very treatable condition with medication, CBT, cognitive behavioral therapy, and ERP, which is exposure and response prevention therapy.
So there is hope for people that are truly struggling with any of these disorders, dissociative identity, or what people still call multiple personality, as well as narcissism, pyromania, OCD. There's hope for them. And what also can be helpful and provide hope is when other people understand, when other people get it, they have compassion, they have tolerance and willingness to come alongside of somebody. So we're hoping that as you listen, you have hope if you're dealing with this, and knowing that you can provide hope. And we do always hope that this podcast is moving the needle away from looking at people with contempt and thinking what's wrong with them, to having compassion and asking, I wonder what happened to them.
Thanks so much for joining us today, and feel free to like, share, and subscribe our podcast, and join us every week for our new episodes.
Thank you as always for listening, and please be sure to leave us a review. While this podcast can't be a replacement for therapy, we hope you enjoyed our discussion today and join us again next time. Nystrom & Associates is always available to those who are struggling. If you find yourself in need of support and help, please check us out at nystromcounseling.com.